presenting a paper on, it's a case report on elevated procalcitonin levels in a patient with DKA in the absence of infection. Because we all know that procalcitonin is an ideal marker for identifying bacterial infection. It helps with early diagnosis, prognosis, and also decision about management. And it's this case report was just showing that procalcitonin levels can be elevated in patients with DKA in the absence of infection. And this procalcitonin level also drops with clinical improvement of the DKA without administration of antibiotics. So just a quick introduction. We all know DKA is an acute major life-threatening complications of diabetic mellitus. And there are different triggers for the DKA. We can have people missing their insulin shots, surgeries, trauma, pancreatitis, and infection. But infection, as we know, it is the most commonest frequent trigger for DKA. And DKA is also associated with leukocytosis because of increase in acute phase reactions like CRP, tumor necrosis factor alpha, interleukin 1, interleukin 6, all which are also increased in bacterial infection. And it has been reported that procalcitonin levels can dramatically be elevated without any focus of infection in patients with DKA. And these levels also decrease in concentration with the improvement of the DKA without antibiotic treatment. So for patients that are coming with DKA, we should not just like a knee-jerk reaction or automated reaction, just place patients on antibiotics. This is because of the need for antibiotic stewardship. And so the case was a 25-year-old white male who presented with a reduced level of consciousness. His symptoms started a few hours before presentation. A year earlier, he was diagnosed with type 1 diabetes and he was controlled with NPH insulin. He also had a history of methamphetamine use. On physical examination, he was tachycardic, had a little hypertension with increased respiratory rate of 34 breaths per minute. He was disoriented, confused with dry mucous membrane. And he has a bilateral non-pitting edema noted up to the distal one part of both legs. His initial lab showed hypoglycemia with blood glucose of 987, which was extremely high. His full laboratory workup was significant for severe anion gap metabolic acidosis, hypokalemia, hypochloremia, hyponatremia, lactic acidosis, ketosis with elevated acetone levels, leukocytosis, and prerenal AKI. So he was diagnosed with having DKA, and his UTOX was also positive for amphetamines. Urinalysis was negative for any pyuria, leukocyte esterase, or nitrite. His chest X-ray was clear. There was no infiltrate or consolidation. EKG shows signs consistent with hypokalemia, and blood cultures were drawn. His initial procalcitonin level was just mildly elevated at 0.87. So he was given IV fluid replacement, IV insulin, and admitted in an ICU, and his glucose was closely monitored. So these were his lab work over 3 days he was on admission. So if you can look at his procalcitonin level, initially was 0.87. By day 2, it went up to 15.8. By day 3, it went down, it trended down spontaneously without any antibiotic treatment to 4.7. And the other labs are just shown just to give a picture of how he presented and how his other labs improved as his DKA resolved. So blood cultures on day 3 were negative. The echo, because of his history of meth use, we did an echo and it showed normal injection fractions with no vegetation. Also because of the bilateral lower extremity edema, we did a lower extremity duplex, which was negative for any DVT. So he did not have any signs of infection except the elevated procalcitonin. So he didn't have any fever, There was no, his urine was clear, chest X-ray was clear. So we just felt we could watch the patients because procalcitonin level was the only thing we had that was showing he may have some form of infection. But because we didn't have any other signs, we didn't treat him with any antibiotics, and his procalcitonin level spontaneously trended down by day 3 to 4.7. So, as we all know, procalcitonin is produced by the C cells of the thyroid gland. It's a prohormone of calcitonin, which is intracellularly cleaved by the proteolytic enzymes into the active hormones. It's a biomarker of inflammatory response, including but not limited to systemic bacterial infection. And usually in healthy subjects, it is undetectable. It is induced in most tissues, especially the lungs and the intestine, and is released into the systemic circulation if there's a bacterial infection. Bacterial endotoxins and cytokines, including tumor necrosis factor alpha, interleukin 1 and 6, also stimulate the synthesis of procalcitonin. And it's important to note that leukocytes do not play any role in the procalcitonin production during sepsis. And other things may also raise procalcitonin level. Non-infectious causes can include burns, trauma, or pancreatitis. So we looked at other case reports and other studies done. Ano et al. in 2020, it demonstrated that procalcitonin levels were elevated in patients with type 1 diabetes in the setting of DKA. And they theorized that this increased procalcitonin level may constitute a biomarker of DKA without infection. So they stipulated that although they didn't know the reason why procalcitonin level were elevated, but it was speculated that because of the metabolic cytokine storms and some signal transduction with such elevation, were associated with such elevations. But however, the exact mechanism remains unknown. Also, Ivanska et al., was in 2016, they also reported that procalcitonin level may show a considerable elevation in children with DKA without an invasive bacterial infection. And procalcitonin level was said to correlate with the severity of hypoglycemia and acidosis. So they theorized that this was related to the hyperlactatemia associated with the DKA or the elevated level of cytokine storm like the tumor necrosis factor and likely interleukin 1 and 6 also. But the relevance of these observations and synthesis in adult patients remained uncertain because it was carried out in children. So just like our patient, we see that procalcitonin levels can be increased in patients in DKA without any infection, without any bacterial infection ongoing to trigger the DKA. So, but we don't know why this is happening for now. And it's important to know this so that we don't unnecessarily give antibiotics when we're not supposed to prevent resistance, to prevent development of antibiotic-related complications, and to reduce the alteration of the native flora. So in conclusion, I just want everybody to be aware that, being cognizant of the fact that procalcitonin levels can be elevated in patients with DKA without any signs of infection will promote antibiotic stewardship. It will reduce antibiotic exposure and reduce the development of resistance. And we have several studies that has shown that this is something that is replicated in other places. But however, the mechanism by which these DKA these procalcitonin levels occur in DKA remains unknown. And these are some of my references. Thank you. If you have any questions, please.